My background is from a otology background, secondary referral syndrome. So I mainly treated Tympanic syndrome, taken tube syndrome, middle ear related tinnitus, and this is the way I've come to treat tinnitus patients. Now, we're all very familiar with the idea of differentiation neuroplasticity. Hair cells gone down, and then neuroplastic changes, which I imagine must be something like this, which make for tinnitus at the central level. Now, most of what I'm going to tell you is based on the work of Susan Shore. I found it wonderful what she's done. And she showed that there's a trigeminal cervical input to the dorsal-cochlear nucleus. And she also showed that if you eliminate your hair cells, you get this neuroplasticity, these changes at the dorsal-cochlear nuclear level, which then provoke tinnitus at a higher level. Now, there's also another sort of neuroplasticity, with I call physiological neuroplasticity, which is adaptation, learning, and which is, in my opinion, much more prevalent than the differentiation neuroplasticity. We all have at the cortical level frequencies which we hear better, for which probably more neurons are related to certain frequencies, and we all have this best frequency that we will hear better. Now, Weinberger did a lot of research in others as well, and when they gave a conditioned stimulus, so a certain sound frequency related to an electrical shock, and an unconditioned stimulus, so a sound frequency without electric shock, they saw that very quickly this best frequency shifts. So the neurons, through neuroplasticity, are going to rearrange them and more connect to that dangerous frequency. And this is post minus pre. So you see that this becomes the new best frequency. This was the earlier best frequency. But the neuroplasticity takes place all over the frequency spectrum, not just for these specific frequencies. Now, there are a few things that are necessary for this kind of neuroplasticity to take place. One is that you need conditioning. So you need a stimulus that is related to something that may cause harm or do something to you. And then there's a sense of urgency that's related to the basal nucleus in the brain. As long as there's no sense of urgency, as life is going its ordinary way, you won't have this time of neuroplasticity. If you feel that your world is being torn apart, that life is difficult, that something has to happen, that you won't handle it, then you will have this kind of neuroplasticity. It's a recalibration of the brain. Now, as you see, you want this frequency, but you'll get neuroplasticity all over the frequency range. Now, I've been busy with listening, and I think there's a peripheral listening system, and I would invite you to do a small test. So you just imagine that somebody is sitting at 1 meter on your right, and he or she is telling you something that you want to hear that's very important to you, but he's whispering. So you really are going to listen very intently to what that person, try it. So what do you feel? You're going to feel some tension around your ears. Your mimic muscles are going to contract. Your jaw muscles are going to contract to the right side. And strangely enough, you're doing something to your tongue. Your tongue is very often going to shift to the right. And you're doing something to your palate. You may feel a little tension in your palate. So when you listen to the other side, there's another person whispering on the left side. And you feel you're going to shape your face in a different direction, put your tongue in a different way, and put your palate in a different way also. Now, imagine I give you a tone, low frequency, soft tone. Oh, it's going softer and softer. You want to hear it. So you want to predict, you want to really perceive it. You're going to do a lot of things with your face, your jaw muscles, but also again with your mouth, with your tongue. Now, another exercise. When I ask you to be completely at still and listen to your heartbeat or your own breathing, but very intently, really, you want to hear it. Some people may notice that they're going to do something to their palate, but in a different way. They're going to pull it up. So that's the levator veli palatini, which opens up your eustachian tube. So you see, when you listen, you're doing a lot of things. You're activating a lot of muscles. And the question is, what are you doing? At the center of this system, we believe is the tensor tympani muscle. And we've known for many years what it does. It contracts when there's external sound, so bottom-up contraction. When you speak, when you want to speak, when you intend to speak, or when you're swallowing, it will contract. It's part of the startle reaction. When you contract your other jaw muscles, neck muscles, it will have to contract as well. And when sensory areas on the face are stimulated, for example, electrically, it will have to contract also. If it contracts for a prolonged time, too much contraction, too prolonged, exaggerated contraction, you get the tensor tympani syndrome, which causes all kinds of symptoms, clusters of symptoms related to muscular tension, related to hearing, related to sensory hyperactivation. And the cardinal symptom is fullness feeling in the ear. And in a classical ENT practice, peripheral second line ENT practice, you see this tensor tympani syndrome very, very often. Acoustic shock syndrome is very much related. It is people who are contracted the tensor tympani for a long time, and then they get a trigger, a sound trigger. And in acoustic shock syndrome, you get much more preponderance of the central symptoms, hyperacusis, tinnitus, concentration problems, anxiety. Petalus eustachian tube syndrome, very strange. There's a large proportion of Petalus eustachian tube patients who have exactly the same symptoms as tensor tympani syndrome plus autophony. So it's tensor tympani syndrome plus an internal sound. And if you treat it, the tensor tympani syndrome symptoms disappear as well. Same with third window syndromes, post-stapedotomy, intracranial hypertension, and hypotension. These are all very similar. Now, this tensor tympani, what it does is, when it contracts, it's going to increase the stiffness of the upper half of the tympanic membrane. The upper half of the tympanic membrane is related to the lower frequencies, 250 to 1000 hertz. So what you see is these lower frequencies will be damped. The more you contract your tensor tympani, the more these lower frequencies will be damped. The higher frequencies will go up, will give more vibrations, but not in an uniform way. You'll see some spikes, some little mountains going up. So this is a signature of tensor tympani contraction put on an audiogram. Now, these are some audiograms of our audiologists, and they were a little bit frightened because they all had a dip at 4000 hertz, 6000 hertz, but these were very hardworking girls that protected their ears. So what we did is we measured the frequencies in between, which you normally don't measure, and then you see that you get the same tensor tympani signature. And this 4000 or 6000 hertz dip is not related to hearing loss, hair cell loss, but actually it's this dip or this dip that you will see. This, for example, is a 75-year-old tinnitus patient. And if you see this audiogram, you say, okay, this is differentiation, high frequency hearing loss, hair cell problems. But if you correct for his age, you see, okay, there's a presbyacusis, of course. But again, this is a tensor tympani signature. And once you get to see it, you see it all the time. It's all over there. The only thing you see on your audiogram normally is this low frequency hearing loss, because you'll miss all the little tips that are extending up. Low frequency hearing loss and a dip at 4000 hertz. Now, what can you do? The tensor tympani is going to stiffen the upper half of the tympanic membrane to stretch it, to increase its stiffness. So if you do this artificially, you just apply a cigarette paper on the two upper quadrants, the region that is stiffened by tensor tympani, the muscle will have to relax. And I've been doing this since 2006, and it helps for tensor tympani syndrome and all the related complaints. It works very well for fullness feeling in the ear. This was a small prospective study because the effect is so clear. But it also helps for some types of tinnitus, hyperacusis, autophony, pulsatile sounds. Pulsatile tinnitus very often reacts to tympanic patching. Burning mouth syndrome, very good tension type headaches, sometimes some facial pains, and PPPD. So a typical psychologically tinted vertigo reacts as well. It's a very simple thing to do, and it's a bit hocus pocus. Patients like it very much. Now, as this is about tinnitus, the question is which types of tinnitus respond to tympanic patching. So it's the tinnitus that is allowed, that can be modulated, that is variable. When people tell me each time I go to the restaurant, I come home, it's louder, I say, okay, I like this kind of tinnitus, this is a good one. So it's louder after sound exposure. Great, this is peripheral. When there's internal sounds like pulsatile tinnitus, when there's somatosensory components, and all kinds of variable and reactive tinnitus will not always, but often respond to this. When it's combined by other tensor tympani syndrome related symptoms, you have a good chance of effect. The ones that are best are the flexed areas. So flexed area is an area on the tympanic membrane that's a little bit floppy. So you can imagine that this part of this tympanic membrane is going to vibrate in a certain phase, and that this area, which is much smaller, may be a little bit floppy. Vibrate, perhaps the phase will not be totally the same. So these flexed areas, they are bingo. You put a patch on it and you always have a good result. This is another patient. So there's some calcification down here, but you see there, you can really see how this is very, very floppy. This is not a normal type of tympanic membrane. It's too thin. So you can put a patch, you don't see them very clearly, but there's a patch there for this one, there's a patch here for this one, there's a patch there for this one, and I put a patch here also. And these always give very good results. So flexed areas are very important. Another thing that appears to be important is adhesions at the nasopharyngeal level. So this is your nasopharynx. This is the right eustachian tube entrance, the cartilage of the eustachian tube. There's the cartilage of your left eustachian tube, and you see an adhesion. It's scar tissue. Now, the idea is that your tensor veli palatini, your TVP, wants to close the eustachian tube, and it's going to pull, but this adhesion is going to pull in the other way. So your tensor veli palatini is going to have to contract all over and cause some symptoms. Once you remove the adhesion, the tensor veli palatini can relax and symptoms will disappear. Here's another one, right eustachian tube, left eustachian tube, adhesions. Now, this is a maneuver you can do, but the results are less outspoken than for the tympanic patching. It may help, but sometimes, very often, it doesn't help, and it's not such a nice procedure for the patient. So all these observations brought us to this hypothesis that whenever we listen, we're going to contract our muscles, as we did just 5 minutes ago. And actually, what we're doing is we're going to contract our tensor tympani, we're going to contract our TVP, our lateral and medial pterygoid muscles. So these, by the volume effect, are going to close the eustachian tube. It's like a cord you're pulling. You're going to close your eustachian tube, which makes you shift your attention to outward sounds. You're going to diminish your attention to body sounds, inward sounds, and really going to guide it to the outside world. And at the same time, by increasing the stiffness of your tympanic membrane, you're going to be a little bit better at perceiving middle frequency sounds, and your low frequency sounds will be damped, which is actually the same as a hearing aid does in difficult circumstances. But at the same time, this may be the input for the trigeminal cervical inputs described by Susan Shore, which activate the dorsocochlear nucleus and makes you hear sharper, clearer. The sound will come in on a more intrusive way on a central level. So this is what I tell my patients. Every time you listen, doing something at an acoustic physical level, and you're doing something at a neural level. So the inputs are the inputs of tensor tympani. You will get an activation of this listening system, as I call it, when you want to listen, of course, but also when you're alert. When you're very alert, you're going to listen 24 hours a day, day and night. Even during your sleep, you may be listening. It will be activated by sound exposure. When you want to damp body sounds, your breathing, your voice, your heart pulse, your vascular sounds, you will activate the system. It's like a filter for unwanted body sounds. When you're going to contract your masticatory muscles, your masseter pterygoid muscles, or your neck muscles, you're going to activate the system. So if you have a TMG problem and you're continuously contracting these muscles, the idea is that you're continuously listening as well. And you will activate it when you're stimulated on sensory level. For example, many people feel that they have pain in the ear when they walk in a cold wind on the beach in winter. And I think this is the tensor tympani TVP contracting also. The outputs will be very diverse, the same as what you see in tensor tympani syndrome, and your hearing will get clearer, or you can damp sound. So you're going to bring some relief into the soundscape. You're going to attract some voices and put some voices in a less clear way. You're going to damp your body sounds. You're going to put in a physical way your antennae, your hearing, your vision, your smell, all the antennae getting up higher so you get more input. And on a sensory level, you're going to activate these antennae. So your hearing will become a bit clearer, brighter, you'll perceive sounds better. It is related to eye movement, so maybe you're going to move your eyes a bit faster, I'm not sure. Maybe your smell, the trigeminal aspect, will become a bit stronger, I'm not sure. But what I'm sure of is that you activate your skin, your trigeminal sensory areas, they can really become very sensitive. So this is actually like a radar that's activated, so you get more input from the outside world in situations when you think this world is dangerous. Now, symptoms of increased output are related to this. You can have sometimes of tinnitus, you can have loudness hyperacusis, and I think hyperacusis may be peripheral or central, but well, maybe 50-50. You can get a problem with filtering body sounds, so they come through pulsatile sounds, autophony. You get this fullness feeling, of course, this is always there, but also other symptoms related to muscular tension. And you can get some sensory activation of the equilibrium, PPPD vertigo, of the tongue, for example, of the facial area. Now, why do you have an increased output? There are two mechanisms. One is strain. When there's a lot of input all the time, you get, of course, an increased output at the end. So strain is when you put a lot of listening effort because you need it on your job, because your hearing is bad, or because you're anxious, because there's a lot of anxiety or stress, then you will have an increased input to the system and, of course, an increased output. When you're continuously exposed to sound, when you need to damp body sounds in a breathless eustachian tube or a third window syndrome, you have to filter out the body sounds, which will cause your system to activate and which will cause the tensor tympani symptoms. TMG dysfunctions, sensory much less. Another mechanism may be that the input is perfectly normal, but that the response is exaggerated, typically in fibromyalgia. But it can be localized also, so dental problems may cause local neuroinflammation and activate the system. And we see, for example, in hyperacusis patients that every time they're exposed to a sound that is not really harmful in the classical sense, that they get to a higher level of hyperacusis. And it's very similar to what fibromyalgia patients experience in terms of pain. So we don't know in a particular patient or in general, is this sensitization taking place before the muscle? Will the muscle contract much too hard? Is it taking place on a central level? So the muscle would react normally, but the central response will be too exaggerated via TT and TVP, or can it be directly from masseter, pterygoid, neck muscles also? So these things we don't know. Now, about the same time as I was thinking about these things, Arno Norena did some research and he really showed that it exists. So this is really data from now on. And he showed that in some patients, sensitized patients, if you give them a sound impulse or some sensory impulse or another stimulus, then this tensor tympani will really move and react and contract very hard. And it's very impressive to see with this pressure measuring device how you can make the tympanic membrane move with a stimulus that doesn't give anything else in other patients. So in these patients, it's really via TT and then centrally. I think that all that is related to somatosensory tinnitus is somehow related to this, and I'm not sure if it's sensitization or strain, and I think maybe both. So another interesting thing is that the Regensburg group has, at a certain point, injected cytokine into the otic ganglion, and they noticed that tinnitus decreased during a few hours after they injected cytokine. So I think this is, again, sensitization or sensory pathway. We had similar experience when we injected bupivacaine into masticatory neck muscles, all kinds of muscles. And very often we saw that somatosensory tinnitus and variable or reactive tinnitus diminished for a few hours, even a day, sometimes 2 days after cytokine bupivacaine injection, but never on a long-term basis. Claudia Coelho from Brazil developed a maneuver to massage the palatal aponeurosis, which is stuffed with receptors, stretch receptors. And in selected patients, the patients with tensor tympani syndrome profile, when you do this maneuver, they often feel that their tinnitus diminishes at once, let's say from 7 to 4 or from 7 to 3. So they do it at home for 2-3 weeks, and then it remains at this lower level. So I think this is related to TVP. Frédéric Fenay is going to do something with TVP that's very interesting. Robin Guillard, his works suggest that TVP may be continuously contracting to keep open the airways at night during sleep. So this will be strain to the TVP. And then again, Claudia developed also intramuscular stimulation, and this is something that we use very much in clinical practice. You can have kinesiology, osteopathy, fascia therapy. And this method here, she goes really with a needle inside the muscles and she applies some current, electrical current, and we feel that this is gives very, very good results for tinnitus. So this also, I think, is pointing to the same mechanism. So it's a whole prediction system involving the whole face, the jaw muscles, the neck muscles, the ear, the TTTVP, central pathways. The whole system is a kind of combined prediction system where every element influences every other element in a feed-forward or feedback way. Now, this can last for years, and there are patients who have tinnitus who've had it for 10 years, and you can treat them in a peripheral way. If they never had any sense of urgency, no neuroplasticity has taken place, and it remains peripheral. But if at a certain moment life has been very hard, a depression, a divorce, a period of intense anxiety, other trauma, then you get these neuroplastic changes. So the idea is you get your conditioning, you get a sound, not only one frequency, but several frequencies. This is the tensor tympani signature. You get the conditioning in the sense that they've seen people who tell them, okay, this is hair cell damage, you've done something wrong, you should feel guilty, never go out anymore. Well, this is what they make of it, and they have all kinds of anxiety and guilt unrelated or related to tinnitus. So this is a conditioned stimulus. And then you get a sense of urgency, and then you get these neuroplastic changes, and then the tinnitus becomes central. So from then on, you can treat those peripheral things, but the tinnitus will remain. This is what we often see when we treat muscles, anxiety, flexed areas, tympanic patching, the whole thing, that people tell us, I'm very happy because my vertigo is better, my headache is better, the hyperacusis is better, but the tinnitus remains. So at that moment, we say, okay, this must have been a centralized tinnitus. So this is a bit how we see it. I find it rather easy to see if it's about differentiation, because this is a tinnitus that is always the same. No, there is hearing loss and there are no symptoms, no muscle tensions, no anxiety. In my patient population, we don't see it that much. I think I see the differentiation maybe in 10% of the patients, 20%. But there's, of course, a selection bias. Then you have the trigeminal cervical input or listening system patients, which start peripherally. And then if they have a period of sense of urgency, you get this plasticity, neuroplasticity. And then sometimes after time, the original input calms down. So then there's only the central tinnitus. Now, it's very difficult to know if a patient has peripheral tinnitus or if there has been neuroplasticity. I think you can only treat, and after treatment, see does the tinnitus diminish or does it remain the same? And then afterwards say, okay, it was peripheral or it is central. So we always treat these patients with first peripheral treatment, and then if the tinnitus remains, we go to bimodal stimulation. If the tinnitus is purely central, of course, it's bimodal stimulation without peripheral treatment. So this is how we do it in listening clinic. This is fairly easy to see if there's any trigeminal cervical input. Is it differentiation or trigeminal cervical? You have your history, you have your exam, you have your audiometry. You send them to the dentist, of course. We put a lot of time and energy in identifying the inputs for a particular patient, and it is sometimes not what you think. So we see a lot of patients who have normal hearing but disturbed speech and noise. So we do speech and noise audiometry in all patients now. And then if somebody with a disturbed speech and noise is a very easygoing person who likes to work in his garden, we don't bother very much about that. But if he has a job that involves a lot of listening effort, combined with this disturbed speech and noise, then it may be very important. And sometimes they have to change jobs, or we put them at home for 6 weeks, just for this factor. We try hearing aids, of course, we do all these maneuvers, and we try anxiety relieving medication for a few weeks. So at the end, we get an idea, okay, it's hypervigilance, it's increased alertness, it's something anatomical, or this is central. And then it's very easy. Once you've done that, you just treat all these inputs, whatever it is. And we work very much with TDCS neuromodulation because it doesn't treat the tinnitus on same, but it's wonderful as a preparatory measurement. They calm down, they decrease their focus, their anxiety, and they're really ready for kinesiology, osteopathy, intermuscular stimulation. And a very strong idea in our way of thinking is they don't go to the kinesiologist before we calm them down. So first treatment of the inputs, and only then they go to the kinesiologist. Because I think as long as your inputs are there, the kinesiologist will do nice things, but it's like working against the current. And once these inputs have calmed down, then they can do work that will give better results and last. So if after the time tinnitus is still there, we say, okay, this is central tinnitus, and then we send them for bimodal stimulation. Not all of them. I think bimodal stimulation is very good to bring a grade 2 or 3 or 5 down to a grade 1, but we don't then send them for a grade 1. The input should be treated first. Pacemaker may be a problem, and their hearing should be more or less okay. So these are our treatment principles. We have exactly the same treatment for facial pain, for autophony, for burning mouth, for vertigo, as for tinnitus, except for the bimodal stimulation, of course, that's only for tinnitus. Because it's all the same. At the peripheral level, these are all symptoms related to the same mechanism. I told you about the strict sequence. No patient see the kinesiologist before the inputs have been treated. And sleep is a very important one for us. As long as they don't sleep, we assume that they're not ready for kinesiology. When they sleep well, okay, then can go, and then this treatment is very effective. We think that we provide tools, but tools are nothing if there's no goal, if there's no drive, if there's no movement. So the movement has to be provided by the patient, and then the tools will facilitate, will help him. So the idea is he needs a lot of insight, so we give a similar talk as this one to the patient, so they get insight, And then we feel if they're willing to go, they have to do the treatment, and we will help them. If they're not interested in the treatment, well, better not to do it. And then I think many patients just need a quick fix. So, okay, my tinnitus is a bit better. I'm very happy, thank you. Life goes on. This is okay, I don't need anything else. But then in some patients, we would be very bad doctors if we just give them a quick fix. If we patch them up, okay, your tinnitus is better. Wow, good doctor, I did a good job. Okay, back to the rat race, enjoy. So these will have other problems. In 6 months, it will be their knee, and a year it will be their stomach. It will always be something. So I think these patients should have a talk at the end of the treatment to go on a long-term road, be it with life coaches, psychologists, be it with continuous TDCS, be it with sports, whatever, life-changing or insight into the problem. And I think that's important for minority, but it's important to tell them that this is possible. So thank you very much.